Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 486 of our pharmacotherapy series, which majors in ischemic and hemorrhagic stroke. We will continue discussing the case of patient PCP in part 485 of this pharmacotherapy series. My next question to you reads: what general treatment interventions should be made for PCP? In addition to the general supportive therapy needed for a hospitalized patient, several issues are important to the proper management of a stroke patient. Assessing vital signs and ensuring stabilization of airway, breathing and circulation is the initial part of the evaluation. Intubation and mechanical ventilation may be required to ensure adequate ventilation and to protect the airways from aspiration. Careful attention should be given to fluid and electrolyte control. Excessive hydration or inadequate sodium supplementation may result in hyponatremia, potentially causing cerebral edema. This can result in compression and displacement of brain tissue, which can disrupt cerebral perfusion. In addition, hyponatremia can produce seizures, which increases the metabolic demand on compromised neurons. Thus, 0.9% saline or lactated ringers are the preferred fluids in patients at risk for cerebral edema. Attention to body temperature needs to be given. Studies have shown that even small increases in temperature are associated with worse outcomes after acute stroke. Hypothermia is neuroprotective, and a reduction in body temperature of 0.26 degrees Fahrenheit can be beneficial in stroke patients. Use of antipyretics, such as acetaminophen, are advised to maintain normal or slightly subnormal body temperatures. Another metabolic parameter that must be followed carefully is the serum glucose concentration, because hypoglycemia may adversely affect ischemic infarction outcomes. A review of multiple studies on the effects of hypoglycemia in acute stroke concluded that hypoglycemia results in poor outcomes and increased mortality. If hypoglycemia is detected, appropriate insulin therapy should be initiated to keep the serum glucose concentration less than 140 mg per deciliter without causing hypoglycemia. Caution should be exercised in the acute management of PCP's blood pressure. Decreasing the blood pressure too rapidly will compromise cerebral blood flow and expand the region of ischemia and infarction, whereas hypertension may place him at a greater risk for cerebral hemorrhage, especially if a thrombolytic agent is used. However, a study comparing treated and untreated patients who were hypertensive in association with an acute stroke failed to demonstrate any difference in outcomes between the groups. For patients with a systolic blood pressure greater than 185 mm of mercury or diastolic blood pressure greater than 110 mm of mercury, who are otherwise candidates for intravenous fibrinolytic treatment, labetalol, nitroglycerin paste, or intravenous nicardipine should be used to reduce the blood pressure to these goals before starting all NAPLEX. A reasonable goal is to lower blood pressure by 15% during the first 24 hours after onset of stroke. After administration of all NAPLEX, a systolic blood pressure should be kept less than 180 systolic, 105 diastolic to limit the risk of intracranial hemorrhage. Specific blood pressure management recommendations are outlined for the management of acute ischemic stroke patients. In other patients, the only consensus on blood pressure control is that treatment is required when pressures exceed 220 systolic, 120 diastolic. If there is a clinical deterioration of neurologic function associated with the reduction of blood pressure, the infusion rate of the antihypertensive agent should be slowed or the drug discontinued. After the first 24 hours of stroke onset, maintenance antihypertensive therapy can then be initiated using an oral agent, such as a thiazide diuretics, calcium channel antagonists or angiotensin-converting enzyme inhibitors or angiotensin II receptor blockers. The general daily needs of the patient should be assessed and provided on an as-needed basis. These include nutrition, urination, defecation, delirium, and prevention of deep venous thrombosis and decubitus ulcers. Neurologic deficits will compromise the ability of many patients to adequately meet these needs, increasing the necessity for medical assistance. The next question reads, should anticoagulation or antiplatelet agents be used acutely in PCP? Several studies have evaluated the use of anticoagulants in the treatment of acute strokes. However, most of these studies are poorly designed or underpowered to determine the efficacy of these agents. Regarding heparin and heparinoids, 3 studies have evaluated the use of heparin in acute stroke. In one double-blind study, heparin doses were adjusted to maintain the partial thromboplastin time, abbreviated as a PTT, at 1.5 to 2 times control and continued for 7 days. There were no significant differences in death at 7 days, no differences in functional ability 1 year after the stroke, and a greater mortality rate at 1 year for heparin-treated patients. Another study compared aspirin, subcutaneous heparin, 5,000 international units or 12,500 international units twice daily, both, and neither treatments for patients with acute ischemic stroke. There was no reduction of mortality or morbidity for patients receiving either dose of heparin. Heparin use has also been studied in progressing stroke, that is stroke with evolving neurologic symptoms, and no benefit was demonstrated with its use. No studies have demonstrated that heparin is useful in mitigating the neurologic effects of a stroke. Low molecular weight heparins and heparinoids have been evaluated in several studies for acute stroke. 2 doses of nadraparin were compared with placebo in one randomized, double-blind, placebo-controlled trial. There were no differences in death rates or functional ability at 3 months among the 3 treatment arms. However, at 6 months, patients receiving high-dose nadraparin, i.e., 4,100 anti-10A international units twice daily had improved function. A large randomized, placebo-controlled trial of dose-adjusted darnaparoid, a low molecular weight heparinoid, did not demonstrate improvement in darnaporoid-treated patients. In addition, no improvements were observed in studies of dalteparin and certeparin. Similar to heparin, low molecular weight heparins and heparinoids are not indicated in the acute treatment of stroke. Deep vein thrombosis and pulmonary embolism are common complications in patients following a stroke. Intermittent compression devices such as Venodynes, which prevent pooling of blood in the lower extremities, should be applied within 24 hours of admission to the hospital unless contraindicated. The incidences of deep vein thrombosis and pulmonary embolism were reduced in most studies in which patients received heparin, low molecular weight heparins, or heparinoids. Unfractionated heparin 5,000 units subcutaneously twice daily or 3 times daily can be initiated in patient PCP for deep venous thrombosis prophylaxis after 24 hours of thrombolytic administration once a repeat head CT ruled out intracerebral hemorrhage. Heparin is considered a cheap and effective option compared to low molecular weight heparins. Regarding antiplatelets, let's begin with aspirin. One study evaluated early administration of aspirin in acute stroke. The Chinese acute stroke trial compared 160 mg per day of aspirin administered within 48 hours of the onset of stroke symptoms with placebo. Patients who received aspirin had reduced early mortality rates, but there was no difference in the primary endpoint of death or dependency at discharge from the hospital. 2 other studies did not demonstrate benefit with aspirin. When data from these studies are combined, a slight beneficial effect of aspirin is seen with regard to reducing the risk of early stroke recurrence. Current recommendations are for aspirin 325 mg to be administered within 24 to 48 hours of the onset of stroke symptoms, except when all TEPLIS is administered. When all TEPLIS is given, aspirin should be given 24 to 48 hours after all TEPLIS administration, but still within 48 to 72 hours of onset of stroke symptoms. In our patient, PCP, all TEPLIS was used. Aspirin should not be given until 24 to 48 hours after the end of the all TEPLIS infusion and once a repeat 24-hour head CT ruled intracerebral hemorrhage. There has been limited published evidence available for the usage of other antiplatelets such as clopidogrel or dipyridamole in the acute treatment of ischemic stroke. Small pilot studies suggested some utility to these antiplatelets without providing solid evidence of a clear benefit of the well-established aspirin in acute ischemic stroke treatment. In the clopidogrel with aspirin in acute minor stroke or transient ischemic attack, that is in the CHANCE trial, the investigators randomized in a double-blind, placebo-controlled study 5,170 patients within 24 hours after the onset of symptoms of a minor stroke or transient ischemic attack to an initial loading dose of 300 mg clopidogrel followed by 75 mg per day for 90 days with aspirin at a dose of 75 mg per day for the 21 days, or to placebo plus aspirin 75 mg for 90 days. This study conducted in China found that the combination was superior to aspirin in reducing the risk of stroke in the first 90 days. The patient's selection did not include major stroke or patients who received thrombolytics. Given that our patient received thrombolytic, aspirin is the preferred option. Glycoprotein 2b3a inhibitors. Platelet glycoprotein 2b3a inhibitors have also been studied in acute stroke. A placebo-controlled phase 2 trial of abciximab given within 24 hours of acute stroke showed a trend toward improved functionality in abciximab-treated patients, but the study was not powered to show the significance for this outcome. In another placebo-controlled, Phase 2 study of patients with acute stroke, the direct thrombin inhibitor, argatroban, was associated with statistically significant improvements in neurologic symptoms and daily living activities. The number of patients enrolled in this study was small, but the results show promise. Currently, the use of these agents is limited to clinical trials. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 487.